Our next speaker is Dr. Subhadeep Sarkar, sir. Dr. Subhadeep Sarkar, sir, is presently working as a vitreoretina surgeon and cataract surgeon in Desai Hospital, Kolkata. So, sir did his MBBS from Neil Ratna's Sirkar Medical College and Hospital. And after that, sir did his fellow MS from the Patna Medical College. Sir also did his 3 years senior residence at Regional Institute of Ophthalmology, a medical college in Kolkata. So welcome Dr. Sujit sir and Dr. Subhadeep sir to this our eyesight meeting. So our first talk is diabetic macular edema from understanding to treatment. The speaker is Dr. Sujit Aidya. So I would like to request Sujit sir, please come and present your presentation.
Thank you, Dhruvo. Is my voice audible to you?
Yes, sir, your voice is audible, sir. You can.
Yeah. Thank you so much for your generous words. We will not waste any more time. Straight away, we'll start the. Is the slide visible to everyone?
Yes, sir. Just make it in.
Hello, sir.
Is it visible to everyone?
Can you edit your? Yes. Can you edit your name, sir, Doctor?
I don't know. Is my father's name coming?
Okay, you can edit also, sir.
How to do it? I don't know.
You just click on your name.
Basically, this is being used by my daughter.
Okay.
Sorry, I'm clicking on my name. Rename. Okay. Yeah. Just a second, I'm doing it. Yeah, it's okay now?
Thank you, sir.
Okay. So, thank you, Bayer, for giving me this opportunity to speak a few lines about diabetic macular edema for understanding its pathology to treatment. So, few disclaimer slides. So, as we could see from this slide, the number of diabetic patients is on the rise throughout the world. It is maximum in the continent of Africa, and our India and Southeast Asia is also very much affected. Basically, it is a pandemic. It has affected throughout the world, and we have to be very aware. And as a retina specialist, it is affecting us day to day. We are meeting patients who are having newly inducted diabetic patients, and we are seeing complications which are not even documented till now. So very difficult days are coming for us. And so a little bit about the pathology. DME is basically presence of excess fluid in the macular area of the retina, and basically it causes loss of vision. And there are multiple pathogenesis, and vascular endothelial growth factor, it plays an important role. Basically, there is disruption of the blood retinal barrier. That is the basic pathology that happens in case of that results in accumulation of fluid in the macular area of the retina. So it can affect both type 2 and type 2 diabetic people. And basically, how does it affect? What is the socioeconomic effect of DME? Because it affects mostly the working age people. So there is loss of productivity. People are more dependent on the other family members. So it may cause decrease in productivity, and there are increased chances of depression compared when the people that don't have a normal vision, the productivity comes down. So it affects the broad socioeconomic effect of our life. So it is true, if it is untreated, it may cause severe visual impairment. So we see people, they say us that, can we delay the treatment? Can we postpone the treatment because I have some important functions, I have some financial obligations. Can you do it? So I have to tell my patients, you see, cataract and other disease can be delayed, can be postponed, but once the retina gets dried up, Dhruva, it is visible, audible to you, no?
Yes, sir, it is audible, sir. You can continue, sir. It is audible.
Yeah. So I tell them that once the retina is dried up, once there is irreversible damage to the neurons, to the retinal cells, you cannot bring it back, even if you can pay me in millions of dollars. So you see, it's irreversible damage. So that is the message. Sometimes it's very difficult to pass on to the patients. So so treatment has evolved over the time. We know that laser was once used to be the gold standard. Once you don't have the other alternative way back in 1980s, then came the era of anti-VEGF that has greatly modified the treatment, and also we can now save vision years in people. And obviously it has been on the, it is getting modified every year, every month. We are getting new molecule that is actually helping us in the long way. So way back in 30 years back, I used to talk with my father that we are basically helpless. The only thing that helped us 30 years back, our father, when we were practicing, that the number of diabetic and his complications were far less. But compared to now, we have more complication, more number of diabetic patients, and simultaneously we have better treatment options also. So everything has a check and balance. So you could see from the chart that we started with laser, then we started the anti-VEGF in 2011, and now it is progressing. We are very soon, I've been told that we are expecting aflibercept 8 milligrams soon in India also. That's very good news for the patient and also for us. So what are the factors that they are the key behind the pathogenesis? So you all we know, this is a repeat discussion that there are the factors, vascular endothelial growth factors and placental growth factor. They play an important role in the pathogenesis of inflammations and all those incidents, all those things that we've encountered in DME. So VEGF A, VEGF B. So what is the idea of this slide? That aflibercept will act all the mechanisms. So idea of all the earlier two slides is that to tell that particular like brolucizumab, ranibizumab, they will act in VEGF A or VEGF B. But Eylea is a complete antibody which will act on all the receptors which are thought to be responsible for the mediators in DME. So it is a complete molecule, unlike the other molecules. So I have skipped this slide. I have been told by Dhruvo that to read all this slide. You see, this is a very mother slide which explains to a any ophthalmologic resident that what are the mediators of vascular leakage in edema. Basically, there is impaired retinal blood flow which causes hypoxia. So hypoxia will stimulate all those VEGF receptors, the placental growth factor receptors. So there is the blood retinal barrier is weakened and we have edema, leakage of fluid and other things, proteinaceous material in the retina, resulting in that pathological pictures. So how to stop them? We can stop gate 1, gate 2, gate 3. So in a layman language, Eylea is a molecule that can close all the gate. As a result, definitely it will be a good it is a good weapon for us in the prevention of diabetic macular edema, also for the mitigation of that, unlike the other molecule which can of close 1 or 2 gates. So other summary that VEGF A and VEGF B and PA are the key behind the pathogenesis of DME, and aflibercept is the only global available till now that can target all the 3 receptors. As a result, it is practically also seen that aflibercept do play an important role, and it play a decisive role, if I can say, in treatment of diabetic macular edema. So how do you know a molecule is working? We can do randomized control trial. That is the best way to find out how the molecule is having positive effects, side effects. The real world evidence that the doctors will talk in the meeting and they say what are the experiences. Network meta-analysis, the international guidelines, everything depends on a very good randomized control trial. So mode of action, our own experience by patient cases. So all this, they can give a pool of data, pool of knowledge, so that you can know which molecule is helping the humanity in the best way. So timely and effective treatment. So I want to stress on that that how the treatment of retina, especially diabetic macular edema, is different from all other treatment of the retina of the eye. So nowhere if a DME is not timely treated. So there are 10 layers of retina. You just understand that all these layers are connected electrically. The light falls on the internal limiting membrane and then it is transformed, it is modified, it is transmitted to all the layers of retina and transmitted to the brain. So understand that if there is accumulation of fluid in between the layers, so even if we don't do anything, just pure sugar control can let this fluid out of the retina, because RP has a pumping function, it will just pump out. But the problem is that if you pump out within 1 month and if you pump in 6 months, the difference is that after the fluid is gone, the electrical connection between the layers of the retina are not established. That is the only reason that we should be very prompt, we should be very effective, you should lose no any time, because the more you give time to all this fluid and all those blood inside the internal layers of the retina, so as they go away in time, as they take more time, the result will be that the patient will say that my vision is not very satisfactory. We will do an optical coherence tomography, we will find no fluid is there, the fluid is gone, but the patient is not happy. The only because that the internal connections doesn't establish even after the fluid goes away. So that is very important that we do it timely, we do it in a fast track manner. And always you have to tell the patient that it is a two-way communication. We cannot rely on injection and doctor's prescription. Patient also to maintain and to reduce the fluctuation of sugar. So all this play, and it's a very complex scenario. I find people in day-to-day life that they rely totally on the anti-VEGF to maintain their vision, which is actually wrong. In long term, they are going to lose their very valuable vision. So when they ask me, sir, can I take some time? Can I come back after 2 months and take my injection? I say that this is a advice, this is not a court order. If you want your vision to deteriorate, definitely you can come back after 3 months. It's up to you. I can only advise you. I cannot give you an order. I'm not a magistrate, I'm a doctor. But if you do it time, I can assure you, sir, that your vision can be maintained till your next episode of DME. So there are a few studies which will show the impact of aflibercept in DME. So the first one was Vivid and Vista. So you see, if you come to this the data, you'll find that mean number of injection in a year in a aflibercept, when it is given every 2 monthly, 8 weeks, it is 8.7. And in case of Vista study we have seen, when it is given every 2 monthly, 8 weeks time, it is 8.4. And the number is the vision gain. You can see that compared to laser, the vision gain is significant in both cases. That is obvious how compared to laser, aflibercept will be more effective. There's no doubt on that. So vision gains are observed as early as the first injection. That is even, we find it every day in our practice. And patient receive more than 8 injections through the year 1 and maintain vision gains. That is the most important part, because anybody can give injections and anybody can have early gain. But the injection which can maintain the vision gains will be able to win the trust of the patient. So nowadays I don't give much importance to all the injection patients, because in my town, most of the injection patients have visited all the retinal surgeons in the hope that somebody will have a magic potion and they get cured permanently, which is not possible. So I tell the patient that instead of doctor shopping, they should do more, they should give more stress on the systemic control. So across all these studies, patient treated with Eylea will gain on average of more than 10 liters, and at the 1 year endpoint. So definitely Eylea is demonstrated superiority to lasers. Again, you find in this chart, you will find that patient in the laser group are eligible to receive Eylea. So we will find that patient with aflibercept have gained and have maintained the vision at 1 year time compared to lasers. So meta-analysis and expert intervention guidelines, what are they recommended? So they have told that at 1 year, all efficacy outcomes are significantly favored aflibercept over other anti-VEGF, because we have already in earlier slide told that it is a complete molecule. It will affect, it will block all those receptors that are responsible for mediator of the DME pathway. So theoretically and even in practically, we have found that yes, aflibercept is superior to other molecule, not only in getting early gains, and I use this term that in many cases in my practical experience, that not because aflibercept people has called me and told me a talk. It is my genuine experience that in people who have been subjected to multiple anti-VEGF multiple times without the aflibercept, after one shot of aflibercept, we could gain some. It may be 10%, maybe 20%, maybe 30%, because we have a earlier discussion that the retina repairing capacity of aflibercept till now is incomparable to the other people. So we have seen people who have not responded to any kind of anti-VEGF earlier. They have shown positive signs, even if by 10%, people who are hand movement have become finger counting at 2 meter, 3 meter. For retina patients, such kind of improvement is also very much important. So they have done it. So I tell them, patthar mein bhi phool agar koi khila paya hai, so till now it is aflibercept. So I am very hopeful that 8 milligram will come, we can deliver more to our patients. So you see, BCVA change from baseline at 52 weeks. I think aflibercept is far superior than ranibizumab, and that we already have talked. So head to head, if you go to all the ranibizumab, Eylea, ranibizumab laser, dexamethasone implant, only laser. So in every spare, for mean change in base corrected visual acuity from baseline to 12 months. So, and also thickness of central macular thickness, in every aspect, aflibercept has done better than the others. So it's the most favorable treatment in terms of BCVA improvement in CMT, because that's very important. Because when you do your OCT and show a patient that there was thickness, it has come down, patient is not interested in that. Patient wants actual improvement in his vision, both in qualitative and quantitative part also. So in both sides, we have to give some result to the patient. That patient will tell, yes, sir, with the glasses, I can see better. And also, if you do a scan, you can show you that before injection, before this present injection and after this injection, we could have some anatomical positive changes also. So both should be comparable so that we can, that satisfy the patients. So what are the international guidelines and recommendation? They suggest that aflibercept should be the drug of choice. So you see, this is the part where you can failing in my part. I don't know about others. So it's very difficult to tell people that I want the best molecule and that is the aflibercept. We have to start with biosimilars. And I tell my patients that we'll start with the biosimilars, but after the response, after a month or two, we have to calibrate what was our response, what should be, what is our expectations. And depending on that, we may have to upgrade to the higher molecules. And nowadays, very frankly, I say that after the prices of Eylea has come down, I don't hang on around between. I start with biosimilars, and if I find the patient is okay, he is financially independent enough to go away. So I straight away start with aflibercept. Recently, a doctor in my place, I have told madam that let us start with the best molecule, and that we're getting wonderful result with her. So there are EU retina guidelines, there are Asian guidelines, Diabetic Canada. So all these, they say that they have an positive sign for, they advocate for aflibercept. And can these guideline meta guidelines form an anti-VEGF treatment in clinical practice? You see, what I must say that it cannot form a guideline, but with time, I have been doing retina practice for last 7 to 8 years. I have seen how it has changes the scenario, how people who have been subjected to different anti-VEGF don't show any response, they get frustrated. And when they come to us, I tell that we have a molecule still other doctors have not used. Would you like to go with it? So they say, no. Some say, okay, sir, we'll go with it. Some say, no, sir, we already have done much. Do you have any other issue? Any other problem? So I find that Eylea has been one of the ray of hope for them, as I have found all the patients till now which I've used limited use of aflibercept, that people have some response, even if by 10%, 20%, 30%. Data shows that yes, aflibercept is better than the other. And you see, it shows 57% of patients are on QTL, means every 3-month interval, and the end of 2, they have gain of BCVA. They have significant gain of BCVA from the baseline. So, what is the summary? Every person can achieve meaningful vision gains. That's okay. The study says those. I am saying it that in my practice, I have seen it has gain. It has shown gain. People have gained both in number and also in quality of vision. Meta-analysis and international guidelines and recommendation will suggest that aflibercept should be the drug of choice, but it depends on the condition of the patient. In my part, I have to tell the patients that we can uplift to the aflibercept, but I start with biosimilars, and also that it highlight the effectiveness of the Eylea in clinic or patient regularly present poor visual vision. Yes, patient with high risk factors, patient with poor baseline vision, I am tempted to tell the patient, at least patient should be informed there is a molecule which can give them better results. It depends on the patient to choose, but I inform them right from the biosimilar to aflibercept. You see, sir, we start with this, but if you want, you can start with straight with this, considering your vision, baseline vision is poor. They have told 2040. Practically, 2040 is a very good vision for Indian scenario. I don't think people at 2040 even come to us. This is only for international guideline. In our ground reality, people at 2040 will do their work normally. Only when they are less than 660 or 636, then they will come to us. So that is a very what the trial says and what we find. So 2040 is a very good vision from me and from my area. So thank you so much. Would like to take any question if there are any. Dhruva?
Thank you, sir. Thank you for your wonderful presentation. You cover up all the topics, all the things, and you well explain your practical experience also. Dr. Sujit sir is using lots of aflibercept in my area. Thank you, sir, once again. If there is a question, you can ask to Dr. Sujit Adya, sir, or we can take the question after the second talk also.
I think, Dhruvo, at the end of the
Yeah.
we
We'll
can
take
take
the
the
question
question.
answer
Yeah,
after end of the second talk.
yeah.
So now I would like to welcome Dr. Subhadip Sarkar, sir, for
Yeah.
his topic.
So good evening. Please, Dr. Sujit Adya, please stop sharing your screen. Yeah, thank you. So, am I audible?
Yes, sir, you are audible, sir.
Yeah. So, good evening to all, and thank you, Bayer, for this wonderful academic discussions. So, today I will be discussing on critical information for clinicians to enhance patients' outcomes in neovascular AMT. So these disclaimers, and just going through the global prevalence, world's population is approximately 8.2 billion, and almost 196 million people around the world is suffering from AMD, which may increase up to 288 million in 2040, and it's leading to substantial global burden. So symptoms: blurring of central vision, visual distortion, central scotoma, and general haziness in overall vision. it may appear suddenly or worsen rapidly. So you can see the initial visual symptoms. There is this blurring of central vision, and later on it's worsening visual symptoms. So stages of AMD, early and intermediate AMD occurs when there is buildup of waste material under the retina. With early AMD, there are typical few to no changes in central vision. With intermediate AMD, drusen are larger and may cause changes to central vision. Late AMD, atrophic, that is known as geographic atrophy, and the most aggressive one and the most dreaded one is neovascular AMD, where there is rapid loss of central vision. So diagnosis is multifactorial. You can go through you can record the visual acuity, then Amsler grid chart, where you can see the wavy lines, direct visualization of the retina, then fluorescein angiography, OCT, and indocyanine green angiography. So goals, the most paramount thing about the management of AMD is time. If time is lost, the vision is lost. Early diagnosis is quite essential. Quick access to healthcare is very much needed. Improved clinical efficiency and enhanced communication between patients and healthcare professionals, because this is the most important thing about the management of the AMD, because if we delay, and there will be permanent loss of the vision. So what are the factors drive the key mechanism behind the pathogenesis of wet AMD? So you can see the VEGF-A, placental growth factor, and all are acting over VEGF receptor 1, VEGF receptor 2. So you can see VEGF-A acts via VEGFR1 and 2, where placental growth factor also acts via VEGFR1, and it displaces VEGF, VEGF-A, VEGF-ER2 by displacing VEGF-A. So heterodimers of VEGF-A and placental growth factor can induce and activate VEGFR1 and VEGFR2 and bind to VEGFR1. So excess activation, you can already know from the previous presentation, the similar causes, that is increased vascular leakage and edema and inflammation and pathological neovascularization. So the available anti-VEGF, that is brolucizumab and ranibizumab, they act on VEGF-A, whereas aflibercept, it blocks all VEGF-A, VEGF-B, and placental growth factor. So the currently available all anti-VEGFs are aflibercept, brolucizumab, ranibizumab, and faricimab. Among all these four, the estimated human half-life is 9.1 to 11 days for aflibercept, which is much higher than the other anti-VEGF. So we can go through many RCTs and RWEs. So the first one is ALTAIR, which is multi-center randomized open label phase 4 study in treatment naive patients with neovascular AMD. So in this study, we have two arms. In one arm, we have 2 weeks and treat and extend regime, and other arm, we have 4 weeks and treat and extend regime. That is, injection is given 2 weeks interval, other in 4 weeks interval. So at the end of 96 weeks, we can see in 2 weeks arm, there is a gain of vision about 7.6 letters, whereas in 4 weeks arm, it is 6.1 letter. And the average number of injections among these 96 weeks is 10.4. Now, proportion of patients at which 16 weeks interval can be achieved after 96 weeks, that is 41.5% in 2 weeks arm and 46.3% in 4 weeks term. Here you can see the visual acuity and the gain of the vision, 9 ETDRS letters in 2 weeks arm and 8.4 letters in 4 week arm. So mean number of injections in 2 week arm is 7.2, whereas in 4 week arm it is 6.9. And at the end of the 96 weeks, you can see the visual gain is 7.6 and 6.1. And already I have told that it is 10.4 number of average injections. Now I am coming to the next one is view 1 study, where you can see at 52 weeks, 10.4 letters gain is there. At 96 weeks, 10.2 letter gain is there. And extension of the study period at the end of 212 weeks, that is after the 4 years almost, it is 7.1 letters gain. So vision gains with aflibercept that is maintained through all 5 years. Now, FRB study was showing the six letters gain from the baseline at the end of 24 months. Average number of injections given over 2 years is 13.6, and by 24 months, 24% of the eyes were being treated at an interval of 12 weeks and beyond. Moorfield study showing at the end of 1 year, it is 7.8 letters gain. In second year, 7.7. In third year, 7.6. At the end of the fourth year, it is 6.3. And the average number of injections over the year is, in the first year, it is 7.4. In the second year, 12.3. Third year, 6.5. And at the end of the 4 years, total is 19.3. By month of 24, 52.8% of the eyes were being treated at an interval of 12 weeks and beyond. So Jaggi et al. Also showing that at the end of the first year, it is 11.8 letters gain. At the end of the second year, is 9.8. Third year, 10.5. And at the end of the fourth year, it is 6.6. The main thing that the 35% of the patients met exit criteria and terminated therapy after 2.6 years. So real world patients with ANMD can achieve outcomes comparable to those of RCTs with aflibercept. You can see view 1, average number of injections at the end of first year is 7, and the second year is 4.2, and the letters gain is 8.4 and 7.6. Whereas in Altair, it is 8.7 and 6.9, average number of injections 7.1 and 3.3. That is at the end of the second year, it is 10.4. And at least 58.5% of the total number of the patients are having 12 weeks having more than 12 weeks intervention treatment. And other studies showing it is comparable with the other studies. So aflibercept as a choice of anti-VEGFs in PCV also. So although not common globally, but it is quite common in Asians. It is a diagnosis of the PCV, and PCV is seen among 22.3% to 61.6%. And it is often underdiagnosed. So PLANET study was designed, and it's a prospective multi-center double-masked sham controlled randomized phase 3b/4 clinical study. It is done across 62 centers. Initially 3 monthly doses of aflibercept 2 gram. Thereafter 8 weeks, every 8 weekly, along in one arm, and in another arm it is 4 weekly with PDT. So there are 2 arms. One arm is getting aflibercept monotherapy. In other arm, it is getting aflibercept along with PDT. And you can see at the end of the 52 weeks, the vision gain is almost similar, 10.8 in aflibercept along with active rescue PDT, and 10.7 only aflibercept monotherapy. After 96 weeks, slight decline in aflibercept with active rescue PDT, and aflibercept monotherapy, it is maintaining all through. So active polyp regression in aflibercept monotherapy, it is 8.9% at the week 52, and 44.8% in aflibercept with rescue PDT. And at the end of the 96 weeks, it is 33.1% and 29.1% respectively. Proportion of patients with no evidence of active polyps at the end of 52 weeks, it is 81.7% in aflibercept monotherapy, followed by 88.9% in aflibercept plus rescue PDT. At the end of 96 weeks, it is 82.1% and 85.6% respectively. So across clinical trials, we can see a proactive aflibercept monotherapy achieves clinically meaningful vision gains. You can see the PLANET, View 1, View 2, Vault, Apollo, and all the real-world studies in mostly done in Japan. It is almost same result. So complete polyp regression have been observed across clinical trials and real-world case series with aflibercept in PCV. So ocular safety is of paramount importance. Brolucizumab, faricimab, and aflibercept, where brolucizumab post-marketing rate of rate per 10,000 injection, retinal vasculitis is 5.6 and retinal vascular occlusion is 3.0. Whereas in faricimab, it is retinal vasculitis is 0.11 and retinal vasculitis with occlusion is 0.06. And in aflibercept, it is 0.006 and occlusive retinal vasculitis is 0.002, the least among the three. So now over the years, 20,000 patients from more than 20 countries treated in real world studies, more than 62 million doses sold since launch, more than 1 decade of RCTs and real world and post marketing experience, more than 9 million patient years of exposure, approved in total 7 indications globally: BRVO, CRVO, DME, myopic CNVM, neovascular AMD, NVG, and ROP. And there is quite low rate of endophthalmitis. Thank you.
Thank you, Subhajit sir, for your excellent presentation. Now floor is open. If there is any question, audience, please, you can ask to Dr. Subhadip Sarkar and Dr. Sujit Aidya sir. Hello, Abhishek, are you there?
Yeah, I'm here. I think, Dhruva, there is no question. So if there is no question, so
Question, we can conclude to this meeting.
Yeah.
And Abhishek, do you want to say something on?
no,
this
it's a,
result?
yeah. So thank you, Shobhudip sir and Shurish sir, for an excellent presentation. It is really helpful to our audience because many doctors are they are practicing with good number of DME and PCB AMD patients. So it's really help to them to treat with the patient at the early stage and what the molecule should prescribe in what stage. Really helpful to them. So thank you for your valuable time, and also all audience, thanks for your valuable time. So hopefully we can continue this kind of scientific activity for long run for the benefit of the society. Thanks for your contribution.
There is one thing
Yes,
to Dr.
yes.
Sujit Adho. I think I have met you in back 2013 in Guwahati Medical College
13.
at RIO.
Yes, in 13 I was there.
So I was also there, and fourth counseling took place, and I shifted to Patna Medical College.
Acha, Sudeep, long time.
It's long time.
Because in a short time, I think 3 months, na?
Yes, I was there for 3 months only.
Sudeep, give me your number na, so that I have
Yes.
your number.
So sir, it's also thanks to Bear sir. With this platform, it could be able to meet you with a long time back friends.
So I think Abhishek, please provide my number to Dr. Sujit because I don't want to discuss my mind in the open forum. Okay.
Sure.
And please-
I'll provide your numbers. I'll provide to Dhruva. Dhruva will provide this number to.
Definitely. It's
Sure,
fine.
sir.
It's really great to meet with after so long time.
Long time. After 13 years.
Yeah, almost after 13 years. Definitely after 13 years.
After almost.
Yeah. I will collect the number of Subhadip sir, and I'll give it to you, sir.
Yeah. Okay. Bye.
Okay.
Bye-bye.
Thank you.
Bye.
Thank you. Sir. Thank you
Good
all.
night.